Hi everyone, welcome back to one of our penultimate webinar series. Today I'm with Dr. Israel Puterman, a periodontist based in Washington, DC. And today we're going to be talking about digital dentistry with a focus on implants. I'm sure there's going to be a little bit of focus on surgical guides perhaps, or other aspects of implantology. We're very excited. Well, personally, I'm very excited about this, being a periodontist myself and seeing Dr. Israel across his Instagram over the last 12 to 24 months when I started to come across his work. So for anyone who hasn't checked him out, please do at Implants DC. Dr. Israel is a highly experienced periodontist working in DC. He completed his master's degree at California's Loma, from Canada originally, has extensive experience in complex reconstruction, implantology, providing sedation services, laser technology, and a few other things. So very fortunate to have him here today. And today we're going to be kind of introducing a little bit on digital dentistry, going through a few cases, and hopefully answering many questions that the audience has. Welcome, Israel.
Thank you. Thank you, Alex. I appreciate it. Thank you, everybody.
So we might just get started into the presentation. Israel, please, if there's more to the introduction that I haven't added, please do. For those who haven't been to DC, highly recommend going. It's probably one of my favorite cities in the US, but I'll let Dr. Israel kind of take it away.
Thank you. Thanks, everyone, for spending your evening with me as you see the sunrise behind me over here. And I know how difficult it can be with families after a long day of work to spend an evening listening to a lecture. So I really appreciate the invitation from Alex and all of you for being here. I'll be heading off to work immediately right after this. So while you get to spend time with family, I'll be deep into patients' mouths. Well, we're going to be speaking about, this is a quick lecture, a quick presentation of a couple of complications. Everybody likes to think of implant dentistry, and especially using digital dentistry, incorporating that into the implant dentistry side, as limiting the number of complications. And what we're going to do is just present a couple of interesting scenarios that I had to deal with and how that was done. Like Alex was saying, DC is a very interesting particular city, and a lot of people ask many questions about it, and I'll just give a quick short intro about it. DC is an area that is the most educated city in all of the US. It fully has 23% of the population has a professional or graduate degree. That's not an undergraduate degree, that's not college. That's master's or professional degree, which is 1 out of every 4 people. It's a little crazy. And so what we have to do is really, I look at every patient as somebody who, no matter what they look like coming in the door, they really, I have to know that they are highly educated and they're going to ask many questions, and I have to look at this as a teamwork with them. I don't dictate treatment to them. I discuss options with them, and we really have to take that into account. So who are my patients? Well, who are the worst patients that you can think of? Personally, for me, right up there, they're physicians. The NIH, National Institutes of Health, is about 3 miles up the road. And there's a huge number of physicians per capita in the US. And if you look at different states of how many physicians per capita there are, if you can guess, there's no polling option that I have right now, but if you can guess in your head the number of physicians per capita in the DC area, it's about twice number 2, Massachusetts, wow, which everybody thinks of Boston and Massachusetts as having, basically being the hospital capital of the US, at least, if not the world. Then DC is double that. But if you're really thinking about the worst patients, I know what everyone is thinking, and we're looking at attorneys. So attorneys per capita, number 2 again, Massachusetts. And if you can imagine, what do you think number 1 would be? Alex, what would be your guess?
I was going to say, let's go for 18. Let's keep it consistent.
18. Well, I wish that were the case. I really do.
Wow.
It fully is. Almost 1 out of every 10 people in the district is an attorney.
I was going to say, I guess if you include government and parliament,
That's exactly it.
right.
So I speak with my friends out in California, and they say, I can't believe you treat so many attorneys. And I say, well, these are not litigator type of attorneys. These are government attorneys, and they're almost harmless. They're like the friendly shark that you can kind of get close to. And it's not a great white. Actually, especially Australia, you guys have a lot of experience with some nasty sharks, but these are the almost friendly sharks. They're inquisitive, but don't bite much. But it really is interesting to treat this patient population because everybody comes in and everybody asks questions and everybody wants, they don't just trust, oh, you're the doctor, you tell me what to do. There is no such thing as that in my world. And honestly, it makes for a more interesting and more fun day, I think. So as we start to look at a couple of cases over here, first we're going to look at Lexi. And Lexi is a really nice young gal who obviously broke off number 8 in my world. Do you call it 1-1 or do you call it 11?
1-1.
1-1. Okay, so broke off 1-1. And I'm looking at this case and I say, great. Well, we have great phenotype of tissue. We have lots of interproximal papillae. We have a great vertical height of gingival margin compared to 2-1. And I'm looking at this case as a really simple, easy case on my end over here, being able to give her an implant and eventually a tooth. And I'm a periodontist, so I'm not sure how it works in Australia, but I don't restore any cases. I might provisionalize cases, but I don't make any final restorations. I work as a team with a restorative doctor.
It's fairly simple. Sure.
Same thing?
Yeah.
Okay, good. So, you look at it from the occlusal standpoint, I can still appreciate the thickness of the tissue. I see contour. This looks like slam dunk to me. So I go ahead and I plan my surgical guide with my lab, and I meet with my lab every Monday after work, and we go through a bunch of cases. They have it preloaded onto the software. They set up exactly where they think the implant should go, and then I tweak it. I tell them, no, just move it a little bit more mesial, a little bit more distal. Typically, I tell them to put the implant a little deeper. And you can appreciate over here the facial position of the root. That gives me a lot of good palatal bone to work with. And as long as that facial plate stays in place during the extraction, they do a diagnostic wax up so that I can, or a diagnostic digital setup so that I can see and make sure that the implant is going to have screw access positioning. Now, what I do is oftentimes I'll make a customized healing abutment if I want to preserve the gingival contour. I want to allow for the gingiva to heal appropriately in an anatomical fashion, but yet I don't want to take the risk of having an immediate provisional. A lot of people in my area don't like the risk of an immediate provisional, whether it be the restorative doctor just doesn't love it. And hey, in reality, I work for restorative doctors, and if they don't like it, I'm typically not going to do it. But the customization of a healing abutment really allows for that same advantage without having the risk of an immediate provisional. And that's what this is. This is basically an immediate provisional, a tooth form that's trimmed digitally at the gingival margin. That's all it is. And here's the customized, the surgical guide as well. So I place my implant using the surgical guide into the ideal position. Despite having a thick gingival contour, I've learned over the years that there's nothing better than thick aside from thicker. So I will place a connective tissue graft, slide it using a little tunnel technique under the facial tissue. And here you can see all of it in place. Just one little suture to thicken it up. And now you can appreciate that although it was even contour between 1-1 and 2-1 beforehand. Now 1-1 is even thicker. The implant is even thicker, which is a good starting point. You could see the customized healing abutment really takes that triangular tooth form. It's not a round circle that has to be readapted by the restorative doctor when they want to make a more anatomical tooth shape. They already have something to start with. And this is how the patient leaves that day. Just one little suture holding that connective tissue graft in place, and the customized healing abutment supporting the interproximal papilla, supporting the exact position of the facial margin where I want it to be.
And are they leaving with like a removable retainer or a partial plate? Do you have preferences?
Yeah, so I only make Essex retainers. I do not make state plates or flippers or whatever you'd like to call them. As a periodontist, I hate adjusting them. I'm changing the contour of the facial margin. I'm even changing the contour of the palatal margin. That little customized healing abutment does slightly change the contour of the palatal tissue. I don't want to thin that area so much that it can break. I don't want to be responsible for that. So what I do is I will fabricate an Essex retainer for the patient, and I tell them if they need something. Everyone knows the downside to that is that you can't eat with it. And if the patient does want something to eat with, then I'll tell them, let it heal for 2 weeks. Then they could go back to their restorative doctor. They'll take a scan and then fabricate a flipper. And over the years, I've actually gotten more anal about that myself, is that they'll make the flipper, but I will place the flipper, because a lot of restorative doctors, even the good ones, frankly, good or bad, it really doesn't make a difference. I've seen it from everybody, is that sometimes it's really challenging to tell if the flipper is hitting that palatal area of a healing abutment, whether it be a standard healing abutment or a customized healing abutment. Yeah. So I like to do a double check myself. So after 2 weeks, you can appreciate the nice healing. You can appreciate the lack of inflammation. Just that one suture, no inflammation around it. It looks very, very nice. Maintaining that buccal contour, a little bit tissue overgrowth on the palate. That's not a big deal. I'm much happier to have tissue overgrowth than undergrowth. And after 3 months, allowing it to heal sufficiently, you can still see the maintenance of the contour, although obviously there's been a little bit of shrinkage despite adding the connective tissue graft. You can notice on the adjacent central incisor, the patient had a preparation for a veneer that had fallen off when she came in that day, and that's why that tooth looks like that. But most importantly, from my perspective, the facial margin is even between the two of them, and patient is ready to go. I can see that there's really no inflammation around the site. Everything looks nice and healthy. I even customized a impression post for my referral so that she can deliver the exact precise gingival contour to her laboratory so that they can make a most ideal tooth for this patient. So then patient comes in, and I typically do see patients for what I call a PR check, a post-restoration check, for any anterior case and any interesting posterior case. So she comes in and I say, Alexi, show me that big, nice, beautiful smile. I have to see this. And I say, what? And she looks at me and she goes, is it supposed to look like this? And I say, well, sure. How do you like that? It looks good to me, right? And I say, okay, Alexi, tell me what happened here. And she says that she didn't think that the tooth really fit all that great. And I said, well, okay, tell me how the day went when you were at the dentist. And she says, well, it didn't fit well. And she was pushing and pushing and pushing and pushing, and it hurt a lot. And the dentist made a little adjustment and then put the crown in and said, well, yeah, the tissue's higher up, but let's just let it heal for a couple of weeks and the tissue should come down. And I'm like, eyes bulging out of my head. I'm the type of guy, I wear my heart on my sleeve. I'm not a good poker player. And like, okay, well, the incisal edge is really nice. I like that. Although it could be a little more rounded. I like the interproximal papillae. I love those papillae. And so I say, okay, well, let me give this dentist a call. I'm going to fix this up for you. So I give the dentist a call and I say, hey, what happened? What's going on? She said, yeah, the lab made it like this. And she thought the tissue would come down. And the patient really wanted the tooth that day. And so she felt bad taking the crown away from her and giving her back the removable and saying, I have to adjust it. So she put it in, hoping the tissue would come down. This is a good dentist. She's somewhat of a personal acquaintance also. We have a personal relationship. Say, okay, is it okay if I take over the case for right now? I'll take the crown off. I'll get the patient into a new provisional. Give me a couple of months over here, maybe 3 or 4 months, and I'll get things fixed up, hopefully, and I'll send her back to you for the restoration. Says, yes, I apologize, very humbled, and gives me a full rein to do what I need to do. But you can appreciate that the tissue level was just not the same anymore. So I say, okay, what do I do here? You take out the crown. I look at this, and I hope that all of you can appreciate that this is where the contour is, and this is where the contour should be. And why did the lab make that extra area of contour of the crown? I have no idea why they did that. You guys are restorative doctors. Lab mistakes way better than I do. And you probably have more answers than I do about how that happened. But I look at the clinical situation, removing the crown, and this is what I have. There's some loss of facial contour. There's obviously a vertical loss. Thankfully, I still had that customized healing. I'm not sure why I still had that. I don't usually keep that, but we did still have it. I put it back in, and you can see the deficiency of where the tissue was to where it is right now. Looking at it from the side, you can appreciate the flatness, the concavity that's developed, whereas it was full beforehand. And so what do? Well, wait, there's an old joke. What's the difference between a good periodontist and a bad periodontist? 2 weeks. And so any complication happens to any periodontist, we say, come back in 2 weeks. And patient comes back in 2 weeks, and we say, okay, it's looking better, Lexi. I'm going to do what now?
Wait another 2 weeks.
Wait another 2 weeks. So she comes back, and the tissue's a little bit better. I say, okay, Lexi, it's looking a little bit better. I think Alex knows the answer to this, but what do you do at this point?
Wait another 2 weeks.
Wait another 2 weeks. That's exactly it. So here we are at 6 weeks, and all I've done is just allow the tissue. I've allowed gravity to take hold, and gravity is something that we can fight. And I've allowed for it to bring that tissue down. Obviously, nothing's holding it up. It's going to come down. So at 6 weeks, I say, okay, well, Lexi, we're pretty close. It's not perfect, but we're pretty close. If you would have shown me this 6 weeks ago, I'd have taken it without any doubt. So say, okay, now what I'm going to do is I'm going to make the provisional restoration, and we'll start to shape things up. So here's my provisional. This is not a hand fabricated provisional, of course. I took a scan, sent it off to my lab. My lab made this, and I'm adjusting the cervical area. I'm adjusting the gingival margin area to be able to have the tissue come down, contour a little bit. And here's where we are. So all I had is patience. And I love this quote. What is patience? Patience is what you have when there are too many witnesses and you're scared to do anything, which is what I was. I just didn't know what to do. And all I remembered is that the 2 week difference between good periodontists and bad periodontists, and I just kept giving it 2 weeks. So now the tissue is down. I had patience, and sometimes patience is what we need. But I look at it from the occlusal standpoint and I say, okay, well, I used to have nice big contour, and do I really want to leave it like this or do I not? And that's always a question of, is good enough good enough? There was a complication and now it's good enough. Do I leave it like this or do I want to go that extra mile? And at the same time, you say, well, that extra mile, what's that other expression that I really use a lot is the enemy of good is perfect. And do I want to shoot for perfect or am I happy with good? Well, I'm a glutton for punishment, so I am shooting for perfect. And here you can see the removal of the restoration, the provisional restoration. And you can see that flatness that I had in that provisional to allow for that tissue to come down. And this is using a microblade, an ophthalmic blade, to just separate the tissue from the bone. And you really have to pull very, very tightly so that you don't end up coming out the facial tissue over there. And you take a little connective tissue graft. This doesn't have to be overly large. Wow, that sun rising behind me is changing the lighting in this room, huh?
It is.
So I just tunnel it in, and just to thicken that facial tissue. This doesn't require a whole lot more than this. And I had one suture beforehand. I remember this is the second connective tissue graft I did. I did place a connective tissue graft when I placed the implants. And somebody is wondering whether I charged for the connective tissue graft or whether I charged for the provisional. And no, at this point, I'm giving my good for the world and donating everything for the good of the case. And this is just photography using this the same procedure over here. This is what she looked like when she left, and I did place other sutures. Nowadays, I don't normally do that. I must have felt that there was too much movement. Nowadays, I would actually place those two side sutures, and maybe not the apical suture. Mm-hmm. But you can appreciate the restoration of that facial contour before versus immediately afterwards. So now we wait 3 months and that facial contour has maintained, and now I'm happy with where it is. Mm-hmm. Again, make a customized impression coping, and this is nothing more than composite, flowable composite that's placed around the impression post. Looks like beforehand I used an open tray, and this time I used a closed tray impression post. Mm-hmm. And I suppose I had asked her what she wants to use. And as we're getting close to having this implant restored, the patient says, I'm down in Florida a lot of the year, and I've kind of lost a little faith in this dentist. So I might get it restored in Florida. Do you have anybody in Florida that you recommend? And obviously I do. So I sent her to Dr. Will Martin, who a lot of you might know through the ITI. I've known him, I've gotten to know him very well over the years, and he's a fantastic prosthodontist. And he made the restoration on number 1-1. He did not make the restoration on 2-1, in case you're wondering. He begged Lexi, he begged her to change her veneer. But really, she had just made the veneer within a year. And she didn't want to pay for another veneer. So he does see her every now and then because she lives in part of the year in northern Florida. And one of these years, he's going to be able to convince her to change that restoration so that we can have two more evenly contoured teeth.
Just out of curiosity, so when you are seeing new patients, they're all getting intraoral scans, I imagine?
They're not. So it really depends on, I wish, and we talk about that often in the office, of every new patient should have intraoral scans.
Well, implant patients say.
Okay, well, I would love it, frankly, if it was every patient. But one of these years.
Yeah.
Every implant patient that I'm going to be making a surgical guide for. And which patients do I make a surgical guide for? I don't use guided surgery on every implant. I use guided surgery on every anterior implant, and anterior is defined as roughly premolar, first premolar to first premolar, roughly. Mm-hmm. Sometimes I won't on a first premolar, and sometimes I will. Canine to canine exclusively, only guided. Yeah. Only guided. And anything in the posterior that's more than 2 implants, I'll place a premolar and a molar side by side without using guided, or though sometimes I will if space is tight. Our tendency, if space is tight, is to have the implants too close together, and they should be, it's a challenge to separate them enough. Would you prefer that I close the blind? Is it challenging to see me at all, or are you okay?
I mean, it depends what kind of mood you're going for.
I'm looking at myself on my little phone. I just see a dark image.
It is silhouetting with a yellow background behind.
So I'll continue to talk if you hear me.
Yeah, we can hear you.
Okay. So I'll use guided surgery for a lot of those cases, but not exclusively.
Yeah.
And so it isn't. Is this any better? I don't know.
Yeah, no, that is.
Okay. So it's not 100% law in my office, and one of these days it probably will be. But the law is canine to canine.
Yeah. And is that fully guided?
Meaning,
as opposed to like a titanium sleeve, a 2.2 or 2.8
okay.
sleeve.
So that really depends on the tooth size and how much space there is, how much interproximal space. A lot of the lower central incisors have to be the 2.2 sleeve, and they're not fully guided. Basically, it's a starter drill, and once I have the 2.2 drill, and I use Straumann as my implant. Once I use the 2.2 drill, then I have to use the next drill non-guided. And it's just a matter of spacing issues. 90% of them are fully guided. The only reason I wouldn't is if there just isn't enough interproximal space.
Right, understood.
So, Callie, this is one of my most fascinating cases I've had to date. Callie is a osteopathic or homeopathic physician from the Pacific Northwest of the U.S., and she comes to the D.C. And she found a local prosthodontist who's fantastic and wanted him to fix her smile or fix that tooth. And we're looking at the other central incisor as Lexi. And he referred her to me. And he's a prosthodontist who places his own implants, except when he sees a situation like this. And he's smart enough that he knows what not to enter, which is as important as knowing what to enter. So we have this tooth, and I'm sure all of you can appreciate the first thing coming to mind is what happened to this tooth. And I'm sure all of you are thinking of that A word, ankylosis. Mm-hmm. And as we see that the gingival margin is more facial than the other central incisor, we can see that the tooth is more, the gingival margin is more apical than the adjacent tooth. The tooth is more facial than the adjacent tooth. And as we look at the CT slice, you can see the internal resorption, which is often associated with ankylosis. And what I'm looking at as a periodontist who's about to place an implant here is I'm looking at, is there a facial plate? If there is a facial plate, how incredibly thin is that facial plate? So if I have a tooth that is not ankylosed and has a thin facial plate like this, my concern is that I'm going to fracture off that facial plate. If I have a tooth that is ankylosed and has a facial plate like that, that's not even a concern. That's going to happen. And so if you noticed her smile line beforehand, she has a nice big broad smile. She's a pretty girl.
Yeah.
This is a situation I don't want to get into a guided bone regeneration or ridge augmentation situation. I want to avoid all of that. Let's look at the three-dimensional reconstruction from the CT scan. And you can really appreciate that washboard effect of those roots, of how facial they are, how thin the biotype is, and how I can see that there is a facial plate. I don't see a root there. You can see a very thin shell, eggshell appearance of that facial plate over the roots. But that eggshell appearance is, that eggshell is going to be gone as soon as I take out the tooth. So we see the very high scallop. We know that that's high risk of having retraction, of losing papilla. You can see some interproximal inflammation, but on really both sides, bilaterally for some odd reason. But you can see the gingival margin that's more apical. You can see the area of resorption on the mid distal of the tooth. And what I plan to do is, looking at various options. What are the best ways to be able to maintain that buccal root position? I can do or not buccal root position, but the buccal plate position. What's the best way to preserve that contour? I can do a connective tissue graft like I did with the previous patients, if I'm able to maintain that labial plate. But the chances are pretty slim. And so if I'm looking for a technique to be able to best support that labial root, then really PET, partial extraction therapy, or socket shield technique is really the best method that I have, the best tool that I have that will allow me to maintain that contour. So this is what I planned. Again, met with my lab online. They place the implant, I tweak it. And you can also appreciate that the position of the bone on the palatal is not what it was with the last patient. So with this patient, I would be coming out the incisal edge. And so what we're doing is using an angulated screw channel to be able to have a screw retained restoration using a new tooth position. If you can appreciate that over here, it really is, this is the, if you can see my mouse moving on the screen.
Yeah, we can.
So you can see straight line position really comes out the incisal edge, and the angulated screw channel allows for the change of angulation to allow for a screw retained restoration. And here you can appreciate that a lot more. It does have cons. It is not perfect technology, but it is very useful when needed. So I make my surgical guide, or the lab makes my surgical guide. I shouldn't take credit for that. And here you can see the different type of screw for the angulated screw channel. And this is what it looks like with the screw. And this is that same patient. So you can see what it looks like. And that allows for an up to 25-degree angulation change. And if anybody does a lot of guided surgery, we know that we have 17-degree angulation abutments. We have 30-degree. I don't often use 30-degree angled abutments, but 17-degree are very commonly used. They're able to fix most situations where we have angled implants. So 25 degrees is very significant angulation change.
Yeah.
So here's the procedure, a video of the procedure. Now I use a microscope. I use a 3D microscope from Seiler that I'm looking up at a screen, and this is just a direct video feed from my view So
Are
this is
you using that microscope for anterior work only, or any implants or any surgery?
absolutely every single surgery that I do is with the microscope.
Wow.
Yeah. I have two of them. I work out of two rooms, and I have two of them. And I find that it's a complete game changer. Absolutely. So we go through the process of creating that socket shield. And using my surgical guide, I place my implant. You can see it's coming into the palatal position. It's exactly where I want to be. Place my implant. And I can get a sense, if any of you can get a sense as well, that there's just not going to be a whole ton of primary stability. I'm not grabbing a ton of bone. So I'm kind of wondering, geez, am I even going to place a provisional restoration? But this is the part that we all love. Place my provisional. I say, okay, the timing is accurate. Everything is great. And I place it, and I hope some of you are furrowing your brow and say, what exactly happened there? This is real time. This is me looking at it, and right there, I'm having the sweats like all of you would, and I'm saying, geez, what the heck? My assistant is looking at me. I'm looking at her. I'm looking in the mouth. Try on the surgical guide and say, geez, did the implant move a ton while I was placing it, or what happened here? And I say, no, it's where it needs to be. I said, okay, well, am I going to change that provisional and really modify it? And I say, no, the primary stability is not great. It's probably about 20 Newton centimeters. Say there's no need to do that. So I remember the apical position of the gingival margin. I did want to correct that. So I was going to do a connective tissue graft to try to bring the tissue down, help bring the tissue down. So I place my bone graft in the jumping distance. Place a connective tissue graft using a little tunnel technique, not raising a big flap. And I place a healing abutment. I don't have a customized healing abutment. I didn't fabricate one. I fabricated a restoration, and a poorly made restoration at that. So that's just a little bit of periacryl to seal things off. And I say, okay, lab. At this point, I call my lab, and I probably was not very polite. But here, looking at some photos from the case, you can see the facial position. That's 3 millimeters. The facial position of the shield is 3 millimeters from where I want the gingival margin to be. I had my implant into the correct position. Looking at it without the guide in place, you can see that there's a big distance between the implant and the shield. I know that I'm not in the wrong position or anything like that. Place the bone graft and the crown. So what happened here? What would you think happened?
I think your lab's gone for an out of an occlusion approach.
Could be. The crown was basically a duplicate of her existing tooth. They didn't take into account the angulated screw channel. And so it was somehow that got messed up in their process. So this tooth is where the old tooth was, and we did not like that position. So placing that, what I did is I took a scan and I sent it to the lab, and I said, okay, 24 hours, you have 24 hours, not 1 minute more. 24 hours, send me a customized healing abutment. I don't want a new provisional restoration. There's not enough insertion torque. I'm not going to risk it, but I want a customized healing abutment in 24 hours. So I left the patient like this. You can see the connective tissue graft in a place. You can see the gingival position is now nice and even with number 1-1. And
are you leaving some of the connective? Is the connective tissue, none of it's left supragingival, or you are purposely just trying to top up some secondary granulation tissue?
Yeah, a little bit is. I don't mind if a little autogenous tissue is exposed. Obviously, if I was using allograft or xenograft of some sort, that's a different story. And although there's one company coming out with one that claims to be able to have it be allowed to be exposed, we're going to test that out. But so far, I don't trust that at all. And the only thing that I would leave exposed is a little bit of autogen. So I'm okay with that. So I take a CT scan after and say, okay, where's my implant position? Because did I really mess this up or did I not? And you can see the shield. You can see the implant position. No, this is exactly where I want to be. I don't want to be any more angled than this. The implant position looks to be coming out the incisal edge of the adjacent teeth. So, or where the adjacent teeth incisal edges are. Then I know that this is just a error in the fabrication of that provisional. So 24 hours later, the patient comes back. Obviously, I have to tell her what happened. She's sedated, and I wake up and tell her, and you're not going to have a tooth. Yeah, they got to come back tomorrow. Not a big deal. She is the nicest, most understanding.
She's not the shark.
She is not the shark. No, she is great. She's a little goldfish. So here's that customized healing abutment that my lab made. And they use pink resin, which is really nice and highly, highly polished. I used to make these in-house on the day of the procedure. I did them a lot, and it would take me, I'd get down to about 35 minutes was as quick as I can make them using composite. And I was doing them a lot. And I like to think of myself as not very slow, but I can get them down to 35 minutes. And I would charge the patient $200 for it. You know, it would take 15 minutes to extract the tooth and place the implant. And then it would take me 35 minutes to make this. And I said, geez, this is a total waste of my time. And I can never get it as polished as a lab can, of course. Yeah. So now the lab makes them all. Patient comes back 24 hours later, and I think, Callie, this actually looks beautiful. And I love my gingival position, although it's 24 hours. And I'm happy with how things look. We're off to a good start over here. I remove the standard round cylinder healing abutment, and I place my customized healing abutments. And then we wait 3 months. And after 3 months, that gingival margin is still at the same level. In fact, it might be a little too bulky. We might have a little too much tissue. Send it back to the prosthodontist, and he starts to sculpt. Although the sculpting was maintained by that customized healing abutment, there was that little overgrowth that he had to push up a little bit using a provisional restoration. And he does that. And here we are after another 3 months with the fixed provisional in place. But you can appreciate the thickness of that facial tissue now, that contour that is going to be able to be maintained because of that thickness. And that's all because of the connective tissue graft. So we started off with a situation like this that had red flags all over the place, and then have an incredible surgical complication and end up with restoration like this. And if you would have shown me that at the beginning, I don't think I would have believed you, frankly. And here you can appreciate the contour by using that socket shield and using that connective tissue graft. I know of no other technique that's able to allow for that contour that really preserves the shape of the roots. It's not just the emergence, but all the way up the root structure. You can all the way up over here. Where's my mouse? My cursor? No, my cursor left me. So you can appreciate all the way up into the buccal vestibule. Yeah, that contour. This looks like a tooth. This does not look like an implant that had a connective tissue graft. This looks like a tooth, and that can only be done really with that socket shield technique that's used to maintain that contour, because you're really tricking the body into believing that a tooth is there, and nothing looks like a root more than a root does.
I would say a beautiful customized restoration as well.
It is. It is. He's a fantastic prosthodontist, and I should say his name, Eric Markowitz. If you're in the DC area and need a good prosthodontist, he's fantastic. And that is it.
Wow. Thank you so much, Israel, for those two presentations. I'm conscious you have patients to see this morning, so may kind of ask a few questions. I can get things started, see if... So in terms of, I'll ask a few questions. So in that initial case, do you have a customized provisional always ready with your immediate temporaries, I imagine?
Yes. So when my standard technique for placing anterior implants, immediate or not, is to place a customized healing abutment. And that customized healing abutment really helps me guide the tissue and provide something a little bit better for the restorative doctor who doesn't... What I want to avoid is the restorative doctor from having to place either provisional restoration or the final restoration if they skip that step, and that's up to them. I don't want them to have to push the tissue and have the patient be in a little bit of discomfort from that, them thinking that they have to anesthetize the patient, and it's also somewhat unpredictable. You don't know where that tissue is going to end up. And some clinicians are far more skilled and some clinicians are a little bit less skilled at that. And I don't want to leave that into the unknown. So I want to give them the contour as close as possible to where I want the final contour to be, and let them make as few adjustments as possible.
That's a wonderful service. What I was asking was, with your immediate temporaries, such as that lady, would you have a customized healing abutment ready, or are you pretty kind of confident with your case selection that you'll kind of pick the cases that you'll be able to get the primary stability usually?
Okay, great question. So I do not make both, but what I do is, except for this case, I could not do it, obviously. What I would do in that situation, and let's say I had an immediate provisional restoration and I just could not get enough primary stability, but let's say that what we had in this case, that second case, without the malpositioned or malformed tooth, I would just cut the crown down to the margin and create a customized healing abutment from that provisional restoration.
That makes sense.
Yeah. And I always have an S6 retainer that I do. So even though I'm planning for a fixed provisional restoration, I always have them fabricate an S6 retainer just in case.
Yeah. So yeah, that makes a lot of sense. And obviously again, I think in Australia, we're probably slightly slower in adaptation of certain things, but I think there's a lot of value in terms of kind of that customized approach, and something that we're trying to do in our clinic anyway, a lot more. But as you say, part of the challenge can sometimes be making sure all your patients have a scan done. And because for us, I'm not sure if it's different to yourself, but we have patients, sometimes traveling we have a regional clinic and things like that. So the geographic challenges can add kind of,
I'm sure. And even with us, even though it's a small metro area, everybody is within, 3 miles of me, which is about 5 kilometers or so. Even though everybody is very, very close, all the referrals are just getting the information of every patient says, oh yeah, they scanned me. And okay, can you send a scan? We don't want them to leave the office today without a scan. And then they say that they were scanned, but you call the office and they were not scanned. And getting that information from the other office's front desk is like asking for the moon. And nobody knows. And just the communication is very challenging. Even with this, I can imagine if you're coming from a big geographic area, you just have to take everything yourself and not rely on anyone else, I'm sure.
That's what you try and do, yes.
Yeah.
Do you find when you're doing these anterior cases, sometimes a case acceptance with soft tissue grafting, or concerns for pain if patients maybe have had soft tissue grafts before and have had poor experiences? Is that something that you kind of encounter in practice much, or not as much?
I do. It's funny. I actually encounter that much more. I don't think I realized this until your good question, is that I encounter the discussion about pain much more with root coverage procedures than with a connective tissue graft for an implant.
Yeah. But patients may not know that difference.
They may not, exactly. That maybe they're so focused on the implant that, I tell them, oh, and the tissue will naturally shrink. And our counter to that is to add extra bulk. And, oh, by the way, I'll take it from your palate. It's going to hurt like hell. Squeeze that in at the end. I don't really. And maybe because it's just typically just one tooth, that it's not a very big deal discomfort-wise from the palate. But I do use some xenograft material. I don't know if I'm allowed to mention brand names here.
Yeah, if you wish. I think I've seen you use FibroGuide.
Exactly. I do use FibroGuide a good amount with better than mixed results, imperfect, but better than mixed results. So it definitely is favorable, but there are times where it doesn't seem to give me the bulk that I want.
Mm-hmm.
And, I'll often get asked questions about that. Somebody says, oh, it doesn't work all the time. Show me something we do that works all the time. And, I just don't know enough of those things. I think sometimes we tend to be a little bit more picky when it comes to a alternate material than we are. I mean, there are times where I do a connective tissue graft and I just don't get the bulk that I really want. The human body is variable.
Yeah.
And when it comes to autogenous tissue, that if we don't get the result that we want, nobody says, oh, autogenous, I don't really get the result that I want. But with an alternative tissue, we tend to be a little bit more critical of it. So I use both autogenous and FibroGuide, both with good results, although not 100% perfection.
Absolutely. I was gonna say, if you have to open something out of a packet, there's an inherent expectation in it. There's a question by Goldman: is the jumping distance in partial extraction therapy or PET always, I'm assuming, grafted?
It is. At least I do. I will basically, and I know the jumping distance, the literature says, I believe it's about a millimeter and a half, that anything more than that, you should be grafting. Anything less, maybe don't need to. Frankly, from a clinical standpoint, if bone graft particles will fit somewhere, I will place them there. I don't want to leave empty space. I don't want to leave anything to chance. If something is 80% successful, that's not good enough in my books. I want it to be as close to 100% successful as possible. And so even if something should work fine without it, I'm going to do it because I really want to sleep well at night and know that I didn't leave any weak link in the system. I want belt and suspenders and maybe an extra belt.
Absolutely. So, I'll ask a couple more questions and then let you go. But one question was in regards to partial extraction therapy. You kind of mentioned about, a bit about, I guess, case selection and the concerns perhaps, or still early days in terms of literature and the technique being modified over time, obviously, because of the challenges faced. What's been your personal experience more in the long-term or longer-term follow-ups of your partial extraction cases?
So my first partial extraction case, I had a complication that I could speak for about an hour and a half just on that one case. It took, I am not exaggerating, it took, I think, 5 procedures to correct the error that happens. That error happens with the placement of the final restoration that was a little over contoured and cracked the socket shield, and had to remove the shield, resulting in a very big defect that had to be regenerated with the implant in place. And it did take 5 procedures in order for me to really correct it. That was my first experience, and somehow my glutton for punishment, I went back at it. And
how many months or days or weeks or before the next case?
Yeah, it was probably a couple of years for sure. And you know, I don't do a ton of them. I probably do every couple of months or so, or maybe even less than that, maybe 3 or 4 a year. And I've not had another complication with it. Every other case that I've done with it has really been absolutely phenomenal results, and impressive enough that I really do think nowadays, I don't think that there's a better way to maintain natural contour than with socket shield. And like I said, there can be complications, totally disastrous complication, but thankfully I only had the one.
Yeah.
And but it left a lasting scar in my ego.
Memory.
Memory, right?
Absolutely. I think one of the concerns I have is, and perhaps it's again case selection, perhaps more so in cases like periodontitis cases, or trying to understand the patients who may be susceptible to peri-implantitis in the future, and what if depending on the patient, their age, if they develop peri-implantitis and that shield is involved. And as I'm sure you've been in practice for a while, peri-implantitis, because if you do enough and you see your patients, although DC is quite a migratory population in terms of your population.
Every 2 years we have a changeover of the population, whether it be Congress or the White House.
Absolutely. But there was a question, and not in this case due to ankylosis, but in a case where the socket shield was to become, and let's use that gingival symmetry positioning or asymmetry positioning. What if the socket shield had become loose, or the plate had broken, and now you have to remove that buccal plate? Would your management had changed for that case?
Yeah, if that buccal plate had been lost, then I'm not placing the implant. And this is now a ridge augmentation case. Very, very different. This is doing a ridge augmentation, most likely with a flap, unfortunately, and waiting 6 months for that to heal before placing the implant. No connective tissue graft.
Okay, so you would aim for primary closure, or use like a PTFE exposed technique?
No, I don't love using PTFE as a membrane, especially when it comes to the same time as extraction, because I do want primary closure when I'm doing ridge augmentation. I find the results better, and it's very challenging. If the PTFE gets exposed, then you're milking out as much time as you possibly can. And that exposure will get bigger and bigger and bigger. Purposely leaving it exposed, I just haven't had great success with it. I tried a bunch of years ago, and I have much better success with resorbable membranes at the time of extraction, resorbable membranes, and full primary closure.
Yeah, that's good to know. All right, and last question. I'll finish off with a more restorative or lab-based question, since this is where we started off with. What have been the issues you've had with the guides? Do you have issues, or were there early issues that have repeated themselves over time?
Every now and then I have a surgical guide that doesn't quite fit properly. My lab is insistent on getting a CT scan and a intraoral scan that's within 3 months. And I do that. I give that to them. But every now and then there's one that just for whatever reason doesn't quite fit. And thankfully, I think I'm decent at implant placements, and I will just tend to make it happen, make it work. I think that's the only guide complication that I've seen. I've not had a guide that, a little superstitious. I've not had a guide that just put me into the wrong position. I'm sure it happens, but I've not had that from my lab, which is great. I don't take a radiograph when I'm doing guided surgery until the end, but I do take off the guide and I look at the osteotomy, and I visually look to see where it is and make sure that it looks to be in the proper position. And I do guided surgeries probably 2, 3, 4 times a week, and maybe more, maybe 5. And it's so far, it's not put me in the wrong position. But there have been times, maybe twice a year, so not often, that the guide just doesn't seem to fit properly. And if it's not fitting properly, don't force it. I'm not going to sit there adjusting the guide for half an hour to make it fit. No,
that's you solve one aspect of it, and then
I'm not a restorative doctor for a reason.
Absolutely. Well, Israel, thank you so much for a really wonderful lecture. For anyone who's interested in finding out more about Dr. Puterman, please check him out on Instagram. For those heading off to North America, please look out for Surgical Influence on Instagram and their website for courses. But to everyone listening, thank you so much. And to Israel, thank you so much as well.
Well, thank you, Alex. I really, really appreciate it.